Hey, everybody, and welcome to the Open Forum podcast. So here we have with us Tiffany Toulouse. Tiffany is a nurse practitioner. She has her master's and is currently working on a PhD. She has up until very recently been working in the critical care units in Canada. And we're just going to get right into it. Tiffany, why don't you take 2-3 minutes and just tell us who you are, how you came to where you are today. And then we're going to dive on into your experiences and your research, what you've seen, what you found. And yeah, we'll just go from there.
Okay, awesome. Yeah, so my name's Tiffany. I want to just clarify, I was in my nurse practitioner for my master's. I didn't finish it because I didn't write my national licensing exam, but I did bridge into a PhD. So as you said, I've been a registered nurse for 9 years. The first 2 years were in med surg, and I floated across 12 different units to just increase and expedite all my learning. And then for the last 7 before being terminated, I was in critical care in the ER, ICU, trauma, recovery room, kind of just floated amongst all of those different units. And I was also, which we'll talk more in depth about, on the rapid response team for rapid sequence intubation of COVID patients. So they acknowledged my skill set back then, and then I was still terminated in December 1st of 2021. So yeah, you and I talked before recording what the things that we wanted to chat about, and yeah, we can talk about like what I'm seeing, so lived experiences, states of cognitive dissonance, and what this means for our country, the impacts it's had on healthcare, and kind of what's going on in Canada now. So yeah, thanks for having me.
No, it's a pleasure to have you on. Thank you for your time. Look, why don't we start there? What has it been like working on the wards during the COVID pandemic? Obviously, you've seen influenza hit the wards, hit the hospitals in the years prior to 2020. How does it compare for you in what's occurred and how we've handled it in the medical establishment, and yeah, go from there?
Yeah, so it's a really interesting topic. So I have to say, before COVID, before the pandemic, the hospital systems in Canada, in Ontario particularly, where we have, it's documented, this is a fact, the worst patient ratios to nurse ratio. So point is we were already in a very dangerous, very vulnerable healthcare already. So add this. It was almost like we were bound to see it fail, because none of the steps were taken to address capacity at the hospital, and that to me was very, very strange. So fast forward in March of 2020, the whole world gets the announcement, and healthcare is all on board because we don't know what we're dealing with. And I was even on board because I'm like, hey, I agreed with the first lockdown. I was like, we do need a lockdown. We need science to catch up. We need time and science to catch up with each other. All on board. We're waiting. We're at the hospital on top of already being a super stressed system. We were fighting for things like getting PPE in. We had no PPE. We had no respirators. We had, and we're hearing nurses, doctors falling by the hundreds, in Italy. And so the fear is ramping up. So you're dealing with already a poor establishment with tons of holes, tons of staffing issues already to begin with, poor ratios, tack into a fear-based pandemic where you're like, crap, now the fear is so bad we have no PPE. So everything was stacked against healthcare. So, a lot of us, though, being in healthcare, you usually are a pretty resilient individual. I don't think that a lot of people get into healthcare for the money, because it's not really about the money.
No.
It's just not there. Yeah. And, so, we strapped in our boots, like we found our strength. We're like, we are here to help and serve our community. We are going to be pro lockdowns. We are the heroes. And it was great because it finally united, community with healthcare, saying like, it's about time people start recognizing how tough this job is. And so that's, for me, is how I fell into the narrative. I was like, there was no time to exercise critical thinking because you were so terrified. You were fighting with your hospital administrators for PPE, and you're getting all of the news and all of the data from other countries saying like people are falling by the dozens, the hundreds. So, I was all on board. I'm not going to lie. I was all on board. And so much so that they created a rapid response team for rapid sequence intubation of COVID patients. And so again, I got selected. I was one of 5 nurses in the entire organization that got selected for this, and happy to do it because that's what the country does. That's what nurses do. You answer the call. So we're dealing with all of this stuff going on in the background, poor procurement of PPE, mismanagement, poor leadership, poor communication, staffing issues. And then you create, a potential hero team to help stabilize, our communities. Awesome. That unites
Avengers
hope.
assembled. Yeah.
Yeah, 1,000%. Right. And so that's cool. I was on board, happy to help. And then I worked on it. It was a 7-week project before they got rid of the nurses, and just allowed the doctors to continue on with it. So the team was comprised of a respiratory therapist, a critical care nurse, and an anesthetist. And we worked 12-hour shifts, obviously days and nights. And we had pagers, and anytime there was a code, because it had to be protected in our little PPE that we did procure, it had to be protected, and our team would go and stabilize and do CPR, do the blood work, run a normal code blue, protected. So in my 7 weeks, I only, and again, there are different shifts, there are different, this is just my experience. I only dealt with maybe 3 COVID patients. The rest were oncology codes, code blues, and any code that happened, we came regardless, because it should have been protected, because you have to assume that someone could be
infectious.
Yes, absolutely. So, but yeah, in the 7 weeks, I only dealt with 3 that had to go to ICU, fully tubed, and were confirmed COVID. So to me, I was like, that's a very interesting, this isn't matching up with the narrative, and although there's so much circulating fear and anxiety, I was just, something still didn't sit right. So I was like, well, this is interesting.
Yeah,
and
so
then I learned.
For the listeners, Tiffany means that 7 weeks coming from April up until June time of 2020. So in those 7 weeks when everything was really, really bad, the world was on fire. We just learned about COVID crossing borders, the world going into lockdown. So this is not over her whole time working as a nurse during the COVID pandemic. This is just during those 7 weeks on this specialized team.
Beginning, the acute stage. So yes, absolutely. And then I learned an interesting fact from one of our anesthetists, and who told me that the doctors on the team are getting paid $3,000 a 12-hour shift. And I was like, that doesn't sit well with me. That to me seems almost like a bribe. Like, it just doesn't seem right. However, doctors in Canada historically have been underpaid. So I was like, hey, if we've got the funds, it's worth it. That's fine. But when the program continued 7 weeks post June, without nurses and just for the doctors, and the numbers weren't there, I was like, well, coming from the background that I come from in education, I was like, there's bias. That's a big room for bias there. There's financial incentive there. So, so I started to put some pieces of the puzzle together. I was like, I'm not seeing what's representing in the news happening. Our doctors are being incentivized, and I do apologize if this offends any doctors, and not every doctor is the same, right? Moving forward, we can't stigmatize and generalize everyone in the same grouping, because that is where we foster division. But I would say a large majority were being financially incentivized, and this can be backed up with documents showing the pay rates in Ontario of doctors that volunteer in the ICU. This can be, this can be substantiated with the COVID incentives that doctors in the States are getting. I think it's somewhere upwards of $14,000 every time they put someone on a ventilator or they mark it down as a COVID death. So to me, I was like, well, there's bias. So that's how I rule out bias. That's how my brain works. And
just to play very quickly, just to play devil's advocate with the ICU shifts and extra pay for that, someone might easily turn around and say, yeah, but the thing is, this is doctors giving up their own potentially free time and pulling extra shifts, doing 24-hour days or what have you, because they're trying to help out. And it's reasonable to expect that, hey, if you're helping out from your own free time, and it is something that's a high stress environment, it is something that's an environment that is potentially dangerous, then it's reasonable to expect some kind of compensation. For anyone listening, that's a reasonable assumption to make, right?
1,000% agree. 1,000%. You cannot deny that. And we know some people don't, from the Canadian system, nurses across healthcare are paid the same. And when you become a critical care nurse, you have to take so many extra certifications, and learning how to run life support in a ventilator is an acquired skill that, you're right, I really do think ICU nurses, people working in ICU, should get get paid more. Same with the emergency department. It's just a different skill set. But so you're right. People do deserve to be incentivized. They do deserve to be rewarded for their bravery. Absolutely. Those are very good frameworks for us to foster and believe in. But my issue was that this pay of anywhere from $150 to $400 an hour as a physician going into the ICU was not, nurses weren't getting this. And I guess who was training the doctors? The nurses. So right off the bat, I was like, well, this makes no sense. You should be rewarding nurses that are training these doctors on how to work in ICU.
So
but
what exactly were you guys training them to do? Because again,
exactly.
Anyone listening to this will think that really, come on, the doctors are going to be trained for the ICU before they step onto the ward. Come on, Tiff, you're blowing smoke now.
Yeah, exactly. So, so it's doctors, and we all get a general, same with nursing and med school, we all get a general overview of what ventilators, critical care is, but until you work it, until you develop the skill set, until you learn how to titrate, 15 different medications at once to keep this patient in a biochemistry rich environment, whether there be alkaline or acidic, whatever you're trying to manipulate, it takes years. Like it honestly takes years to perfect the skill. So it's not that doctors don't have the intelligence to do it, is they don't have the real world experience of doing it. And you can study all you want. You can do practice scenarios all you want. Everybody's body's different, and it's up to, that's what makes critical care nursing so amazing, is that you every day you're looking at blood work and you're working with your team and saying, how do we adjust, how do we do this? You can't just jump in on that. It takes so long. And that's what those nurses, because and I'm not here to downgrade the role of doctors, they're so valid in healthcare, but nurses are your little, your worker bees at the bedside. In so many nurses, if they're listening, they can attest to the fact that, you've reminded a resident or you've reminded a doctor, are you sure you want to prescribe this? Like, this is, they're anaphylactically allergic to this, or, last time we did this, this is what I observed. So, it was kind of like a Band-Aid approach, just throw doctors in, but there was no foundational exercise, no foundation framework, no education session. It was just nurses are going to train doctors, but nurses are not going to be compensated, and nurses are not also going to be supported by creating another workforce of ICU nurses. So that's what I mean. So you're not wrong to say that. And for people listening, well, Tiffany, that makes no sense, but it's not applicable without practice. You can't just jump into critical care. It is impossible. It is so overwhelming. There is so much to consider. And that is why they didn't make it the goal of the doctors to train the other doctors. They asked the nurses to train the doctors, but didn't compensate the nurses. Right. Or not only did they not compensate the nurses, as a bunch of critical care nurses, we advocated to our governments, our provincial and federal governments, to start training frontline ICU nurses. Like, take kids that are almost out of school or nearing the last, semester, and start putting them in a year of training. And they never did that. They just threw money to the problem. And that created a virtue signaling of saying from the politicians to say, well, we're throwing money out. But with no real plan, just like when they give millions of dollars to the Indigenous community, but they have no plan for it, no accountability, no system to verify, no ethical framework. They did the same approach to ICU, no framework at all.
Interesting.
Yeah.
And then moving on from the rapid response team that you were part of, how was it moving into the summer months where there was a definite lull in COVID numbers, in hospitalizations and whatnot, and then moving back into the following winter in that would have been December of 2020, that year, right? How
October.
How was it for you guys moving back into then?
I can't even describe it, because you're not seeing what the media is portraying, right? And what you're seeing on the inside is delayed cancer screenings, delayed surgeries, and for no justification. And then you're looking around your coworkers and you're like, why aren't we speaking out against this? Like, why aren't we addressing the fact that there are more mental health and suicide attempts in ICU on ventilators than COVID patients? Why aren't we speaking out against this? Because I'm not seeing it. But I also won't deny that we did have about 2-3 waves, and we're not here to discuss what we believe COVID to be, but we did see 2-3 waves of COVID, but also it lined up with normal flu season. Right. So it's like you're sitting there and you're trying to understand what is going on here. and why aren't we publicly, having conversations and open debates about risk benefit, locking down hospitals without increasing capacity like we advocated, but just throwing doctors into ICU when you want ICU nurses that are stretched, burnt out, already underappreciated to train these doctors, but you're not willing to train nursing students to jump into this, give them a 1-year program, or you're not willing to tell the public the hospital's at a lull, let's get our cancer screenings back up, or let's identify 2-3 hospitals in the region to be COVID dominated. And then the other hospitals have to pick up the lockdown slack. They have to pick up the cancer screenings, the missed surgeries. Nothing was happening and nothing matched what we were living and in the media. And so it was like, you really feel like you were in a different universe watching it and living it.
This element of things not matching with what you're seeing in the media to what you had in hospital is something I really, really want to get to. But this thing that you bring up, this idea of, hey, look, why don't we separate out a few hospitals for COVID stuff, and then we're going to do a few hospitals where we can continue relatively normal care, so that we don't have this massive drop off of misdiagnoses of cancer, heart patients. Because one of the big things that we saw, or that you see in the UK, is that there were a lot of patients who had other issues, other conditions, who were afraid to go to hospital. One, because of the fear of potentially something at the hospital, and two, because they heard that the hospitals were so overrun. And I'm not saying that they weren't. I have friends and family that work in healthcare in the hospitals, and obviously you are there as well. And there were times where in the UK that the wards were so full that people were on gurneys, not totally on a ward, right? That is definitely a thing, and we're not here to deny that. But
no,
this
not here
could
to deny
have potentially been aided by separating stuff out and preventing other people from having other issues, whether it might be heart or whether it might be cancer,
strokes. Exactly.
Yeah.
Yes.
So, was there ever any talk about this at your hospital or within your senior management teams? Because I mean, if you're selected,
that's it. That's the problem. You would bring about in team meetings like, hey, why aren't we doing this? Or, we would write to the premier and Justin Trudeau, why aren't we training nurses? Here are interventions. And that's the thing, met with total silence. And it's like, we can agree to disagree. We can view different spectrums of what COVID is. But the point is that the basic hallmarks of our democracy were bypassed. And that is not something to be quiet about, because you're talking about how can we openly work together and create solutions. That wasn't encouraged. How can we reevaluate? We've tried this method not once, twice, 3. Canada's on their 5th lockdown. And nothing's changed, right? Why haven't we created public debates of both sides? Why aren't we sharing resources, knowledge? Why are we sharing just pieces of the puzzle? Like, 100 people died of COVID, but like you said, now it's coming out that, 100 people died of COVID, but 98 of those 100 had 5 or 6 comorbidities. So then why wouldn't we change a target approach to increase, society's health, mental well-being, spirituality, nutrition? And that's what I mean. There's been so many things that we've just missed the mark. And some of it could be because, there was a fear-based logic to it and we just weren't sure. But at one point, we need to take a step back and create panels of advisors. We need to do all of these things to restore our democracy, to restore the faith in healthcare. And none of it was done. And that's not something that we should be quiet about, because look where it has led us. And I can, like I said, I'm not here to deny that there weren't waves in ICU. I'm not. That would be terrible to say that to the nurses that have pulled up their socks and worked their butts off, and same with the doctors. However, I would challenge any nurse listening to this. Tell me if at one point you didn't have more mental health emergencies or suicide attempts or domestic abuses, X, Y, and Z, delayed cancers, which increases the acuity in your ICU than you did COVID. And I don't think any nurse in this country or this world could deny that. And that is not okay. That is cause and concern for you to stand up and say, these lockdowns are far devastating than COVID, or, X, Y, and Z. And, we need to get back to transparent data shade. We need to get back to informing the public and seeing what their opinions. But none of these simple things that we usually do were put into place. They were all completely ignored, demonized, and that to me should make all of the hair on your body stand right up, because it's not okay.
That demonization of any of the talk of if you were to say anything that was contrary to the narrative, for me is really worrying. As you know, if you're unable to talk about it, is that not in itself inherently unscientific? Because science is to question and to find answers for the question and to study and investigate. But are there any is there any way we can look up the stats, the statistics behind those ICU admissions that you mentioned? Because I think that's super important. It's one of the things that's now coming to light in the Netherlands and in the UK, where X amount of people who are in the hospital are actually there for other things, and they just happen to pop positive for COVID from the PCR test. So those people that you're talking about that happen to be there because of suicide attempts or happen to be there because of domestic abuse or some other reason, mental health issues. Is there anywhere within the Canadian statistics that someone could dig deep and find out, hey, actually, during the period after the first wave in that July, August, September time, there were more people in the ICU for XYZ, or during a lockdown, there were more people in the ICU for these other reasons? Or is that quite hard to come by? Is that something that's more going to be a personal experience on the wards?
For now, yeah. For now, unfortunately, in Canada and specifically, I know other countries have started. In Canada, it's still very hush-hush, but I know the research is coming. And I know this because I liaison with a couple of big organizations, one being the Canadian Health Alliance and the other one being the Canadian Frontline Nurses. And so we all liaison with big names like Dennis Frankel, who's a physicist, and he does tons of studies. So those conversations are happening about bringing light to all of that. But as it stands right now, this is part of the information censorship that we are trying to combat, because the general public deserves this information to make informed consent. And that is why we're sending up, because a lot of people have not been given informed consent. A lot of people would not be taking the stance that they were in if they had all of the facts on the table, right? So it's not here yet in Canada, but it is coming, it's emerging. We're liaisoning with some big groups, some people that are heavy into research that are starting to ask these questions, to do this research in Canada. But I will tell you, it's interesting. One thing that is very visible in Canada, and it's kind of annoying, it's that they're able to tell you who's unvaccinated and who's unvaccinated and vaccinated in ICU. So it's like they're able to do it. They're able to tell you that people have 5 or 6 comorbidities because they're already able to tell you about vaccination status. So it's just they're controlling the data that they want to release. So it's coming out. It will eventually come out. It's just a slow process for Canada.
Yeah. I think the statistic out of the US was something like over 90% of people who died of COVID-19 on the ICU, I think it was, had 4 or more comorbidities. And that's also a very important statistic to highlight, because it also highlights a major way that we could potentially identify these people and potentially identify risk factors that we could try to reduce the impact of. And I mean, the other element is there was also ridiculously high percentage of people who had low vitamin D. Now that can be because of lockdowns or what have you. There are obviously all these other things that factor into it. And generally speaking, people have lower vitamin D. And as someone, as a kind of person myself, I've got lower vitamin D. Hey ho, it is what it is. I live in the Northern Hemisphere where there's not as much sun. So there are these elements as well where if you spoke about it, then you were demonized and you were called a denier of the situation. Tiffany, how dare you say there are other factors that go into this? But hold on a minute, 4 or 5 comorbidities, isn't that important? Hold on a minute, lack of nutrition, isn't that important to bring up? Obesity was one of the biggest risk factors. And from my lived experience, now I don't work predominantly just an ICU work. We are ICU overflow in my unit, but I was in charge quite a bit, not always, but enough. And so I would sit on the bed flow meetings in the hospital. And I would say, like, morbidly obese, some of the COVID patients, because we had to prone them in ICU, and it would take like 6 or 7 people to prone them because of their body mass index.
size. So yeah, that's another, like, and that research is all starting to come out across the world. But, are we going to sit there and say, oh, because you're fat, you're the reason? No. But it's like, how about we look at, okay, guys, you need to get outside for 45 minutes, start walking, start taking accountability for your health. Let's mandate exercise. Let's mandate vitamin D. Let's mandate community programs where people start, honing in on their trauma. Like none of that was done. And it's like, but regardless of where you stand on COVID, and regardless if you're demonizing me, these are just good public health measures to have anyways, because, we're thinking these unvaccinated people, they're burden to healthcare. Well, to be honest, it's people that have all these comorbidities that could be the burden on healthcare, but I'm not sitting there and pointing fingers. That's not what nurses do. That's not what healthcare professionals do. It's like, how can we empower you? And one basic thing the politicians and our leadership could have done is that exactly it. Vitamin D, exercise, social connection, meditation, prayer, whatever you need to. But if you've got 4 or 5 comorbidities, we are going to do a bit of a target approach, or you are going to be at a higher risk category. So we're going to push out, information to that group. We're not going to demonize. We're not going to stigmatize. I'm not here to say, because you're overweight, you don't deserve an ICU bed. That is just insane to me that I keep hearing this. You're unvaccinated, you don't deserve an ICU bed. Like, so the thing is, yeah, we need, there's so much that we could have done. And instead, what we're living is the people that are speaking out, trying to advocate for the basics of public health measures, are being named as, like these science deniers. And it's like, I don't understand that. Like, science denying, regardless if you believe in COVID or not, or regardless of where you sit in the COVID narrative, losing weight is the very basic healthy thing that you can do to not stress your system, to not put your risk factors through the roof. And like you said, it is being shown and proven that most people who died of COVID had 4 or 5 different comorbidities. So a target approach, not a target approach that demonizes these individuals, that empowers them, and would have been a very reasonable thing. And I can attest to the fact that a lot of the COVID patients on ventilators were morbidly obese or severely diseased. That's just a fact.
Of the ICU doctors that I've spoken to date, I remember a conversation with one where he said outright, like, I've only had one patient that was not obese and they were severely underweight, which again can go the other way in terms of comorbidities. But otherwise they were mostly obese or severely overweight people. And this is not to fat shame before someone tries to cancel culture, whatever.
Yes.
Moving on from that then, how was it during the peaks of the COVID waves for you guys on the wards? Because I think that's also something important to highlight. As to anyone listening, it probably sounds like we're rallying against the healthcare system as it stands today, and that's not the case. We both work in healthcare, and worked. Fingers crossed, if things go back to normal, you'll be back there too. Was it mostly unvaccinated people? Because since April, or let's say March of 2021, slowly but surely people were getting vaccinated. Then you were able to see a bit of a difference between the two. How was it for you in this last year?
Oh, so I never understood the whole alignment or complete stance of saying there are more unvaccinated individuals in ICU than vaccinated. I never understood that because there was no system of reporting at the beginning. There was no way for people to check. There was none of this. So I don't understand how we could have aligned so strongly in a narrative that was not proven, because there was zero structure or system put in place to propagate that narrative. And then my lived experience is I did not see more unvaccinated versus vaccinated COVID patients. And when I got terminated, the week I got terminated, there were only, I can't name where I used to work for reasons, but we're an organization of 7 hospitals, and two of the 7 hospitals are big acute care settings with a lot of services. And so we took the blunt of COVID patients, as well as we had 1 other sister hospital. So 3 for the region, 3 big hospitals taking on COVID patients. And we have a catchment area, and Canada works in terms of funding based on a catchment areas. So our catchment area was 1.2 million. So just to give people stats. So 1.2 million. And yeah, there's the hospital I worked at plus 2 other hospitals that would offload COVID patients. So 3 major hospitals for a catchment area of 1.2, 7 patients for COVID in my hospital.
And this
3
was October, November
of.
time,
Yeah.
2021, right?
Yeah.
And you guys went back into a lockdown?
We did. Yeah.
When did you go
7.
back into? Yeah.
Oh God, we've had so many, we've had like literally 5 or 6 lockdowns.
But
So
after you were terminated, so from November to now, you guys have been in a lockdown as a result, right?
Yes. Yeah. But the week I got terminated last week. So yeah, I guess the last week of November, and I know this because I was on bed, I was at bed calls, 7 COVID patients in total. That's including not just ICU, that's including, we have like a COVID floor, like just for patients that don't require ventilators that are just still struggling. 7. And so I can't speak for the other 2 hospitals because I didn't have their stats, but that's still to be terminated and to lock down the public, which as we know has far devastating effects, over 7 patients. And also remember, November and October, this is normal flu season for us. Yeah. We would see influenza. Normally, group nursing homes would not allow their residents to go back if they're an outbreak. Like, so again, we're not here to deny. What we're here is to bring awareness of the steps and processes that were completely bypassed or ignored. And when you try to speak of them, try to understand, try to exercise critical thinking through debate, completely, you were down. Then completely. And that's not okay. That's something that we can never allow again, because it has gotten us where we're at. And 7 in my hospital. Like, how? That's it.
It baffles the mind that the steps that were taken and the resulting terminations of people like yourself. And for anyone listening, the reason for termination was vaccine non-compliance, right?
Yeah.
We're allowed to say that?
Yeah, we are, definitely.
Okay,
and non-disclosure, just not refusing to disclose your status, period.
Okay. Yeah. So that's what it is for, your personal medical rights, personal medical privacy, that thing that we're both taught in healthcare, doctors are taught in healthcare, that medical privacy is the most important thing.
The
right?
most important.
Yeah. And do no harm and all the rest of it. But okay. And then the shocking thing there in all of this is the fact that at every step of the way, it seems like the responses from governments across the world, from the provinces across the world, have been to shut everything down and lock people up. And it's counterintuitive when the information comes out that actually a healthier lifestyle benefits massively. And I think it's important to mention as well, it's not impossible for a fit and healthy person to end up in the ICU with COVID, or have a serious disease as a result of COVID, or have long COVID. I know very fit, healthy people that have unfortunately suffered with it. So that's by no means are we saying that the only reason you get it is if you got these 4 or 5 comorbidities and that's it, wipe off. Not at all.
Not at all.
Statistically speaking, you're at such a low risk by these healthier lifestyle choices that were neglected, and if anything, worked against you being able to do. Because if you're locked up, you can't get out, you can't get your vitamin D. You had an hour, some countries were an hour to go out and do exercise, and that was your allowance.
And that, you're right, and that, like, the psychological manipulation, the psychological trauma, and just in that alone, that pressure, that anxiety amongst everything else that's happening. And then to be told that, you have an hour to do this, or to be told that you're not essential, so your job is on hold and you're not going to get paid. Like, all of these things, it's not okay. It's not okay. And there have been so many check-in points for me that have gone completely ignored. And then that's what forced me to, in terms of forced me to awaken, because I was like, whoa, there is something much larger at play here, because it just doesn't make sense. And the fact that you're trying to bring awareness and trying to advocate for things like informed consent, normal public health measures, increasing your exercise, like you said, social connection, because that's your support, and is being played out to be, COVID denier, or it's like enough with the stigmatization, enough of that. That doesn't help us evolve, period. And it's like we've only, filtered ourselves into this one lens. And like you said, this is how science actually works: is we question, we break apart, we evolve, we grow from it. And those basics have been completely ignored, completely bypassed. And it's like, that is not okay. And then you're right. And when we talk about certain themes, people, you're right. Like, I'm happy that we're talking, like, we're not here to deny it. We're bringing light to that, because there are people that have been healthy, have ended up in ICU too. Like, and we don't have to get into the topic of the vaccinated versus the vaccine unvaccinated. But again, it boils down to informed consent, freedom of choice, and real-time data, and I'm not seeing that. And if you're not seeing that, you have to speak out against it, especially in a position of healthcare, of leadership, because we worked so hard for the community to trust us, to build that relationship, and we're allowing it to be destroyed. And that's not okay with me. And that has far greater consequences than all of this, because delayed screening, people not coming in because they don't trust. I have had so many messages, people reaching out to me, telling me their lived experience in the hospital system. And it's enough to bring me to tears. Like, people going 36 hours without pain medication in their palliative, people going 2 days without water, all of this stuff. And it's so wild. And people telling me that, they were stage 3 cancer and now they're terminal because they couldn't get their screening, or, it's like, and all of these things. And it's like, at what point do you not do a risk benefit analysis of even yourself as a human? And you're like, something's not right here. But I'm unfortunately, I'm seeing a lot of really amazing things, but we still have a lot of work to do. And it's bringing awareness and fostering open communication about what's truly going on, while not feeding into polarization, while not feeding into stigmatization, while not feeding into, this versus this, that doesn't help. So.
Yeah, no, absolutely. I mean, that's the reason for the open forum here. So for people to freely be able to talk about, one, the lived experience, and two, the things that are going on. And I think something really important for us to highlight here is one thing that you mentioned there, the real-time data, because we have to look at the signals. Everything here is so new. We've got this modification. We got this SARS-CoV-2 virus, COVID-19. It's brand new. Like you said, I also believed in the lockdowns and the necessary the necessary evil, let's say, right at the beginning of keeping everyone in their homes and whatnot. I was scared to go to work. My old manager could tell you I was a proper piece of shit about it. Like, guys, I'm not coming in until you get that PPE, sitting back and like, no, you guys need to secure this stuff before I get in there, because I'm not risking my health, blah, blah, blah. Yeah. Real fucking sour puss I was. But
say me too. I was mask up, wear 6 masks, be in a bubble. I was on board. And then 7 weeks, everything changed.
7 weeks, everything changed for you. For me, it was the fact of, I also, aside from working physiotherapy, I also have a degree in physiology. And one of the things that we looked over in human phys was the process for drug manufacturing, vaccine manufacturing, and why there are these long processes behind it. Chemistry for biology, why we need to see the long-term effects, and seeing something pass in 6 months, where in the trial phase they even stopped partway through to vaccinate the placebo group, or portions of the placebo group, for their benefit, what have you. That irked me, massively irked me. And then also coming in contact with people and nothing happening, or what have you. But it's paying attention to these signals that we have in the data, because those signals, scientifically speaking, should be things that we should explore. So when we have a signal of loads of comorbidities, that should be something spoken about and explored. When we have a signal of these nutritional deficits, if we can improve those, is there something there? If there's a signal of, hey, these countries in Africa seem to be using this medication, this Voldemort of medications, ivermectin, that he who should not be named, they all seem to be having magic numbers. Why is that? Is it because they're living this forestation life, or something? I've literally heard that, because they're living outdoors, blah, blah, blah. That's what it is. I just thought to myself, that is ridiculous. You've literally just seen a picture from a UNICEF advert and assume that's all of Africa. Are you insane?
But cognitive dissonance, right?
Yeah, it's outright denial of the things that are in front of your face, the lived experience versus what you're being told and shown in the media. And the media is something that we've not yet touched on. But yeah, as a scientist, as someone going through a PhD at the moment, you very astutely need to look at indications in the data, right?
Yes. Yeah. And I don't like, and that's why even like we talk about bringing awareness to this and people automatically want to group you in, and we're not going to do that anymore because it doesn't help anything. So I'm not here, to group, but I'm getting my PhD. I have a 4.0 in nursing research. Like I like to think that I'm well-versed in research, still learning, but to make a comparison to ivermectin, like I'm looking at people and I'm not downplaying, what they're going through. I'm not downplaying their lived experience. I'm not downplaying their fear, but I want them to see, like you said, the real-time data. Ivermectin real-time data won a Nobel Prize for its abilities to heal in 2015, and we're going to group it in as a horse dewormer. I'm like, are you for real? Like that is, and not just that, fine. You don't want to believe me about the Nobel Prize in 2015. Go do your own research, see what resonates within you. Ivermectin, hydrochloroquine, vitamin A, B, C, D, zinc, quercetin, a bunch of other supplements and medications were handed out in packets. And I can send this to you after this. You can share it, of countries in South America. And I forget the two countries off the top of my head.
I think Peru is one of them. And
I
they
think
even
Peru
had a video of it with one of their ministers talking about what they're giving out.
What they're giving out, they're literally giving their citizens this stuff out. And how is it that but not necessarily a third world country, but a poorer country than the first world countries did these early interventions, which included ivermectin, and came out on top? So you want me to align with a narrative, but you're not willing to break it down or treat me with respect or consider or have an open-minded. And so then you want me to just blindly follow. I don't work like that. And a lot of people don't work like that. So, and unfortunately what's been happening is with the media, and we'll get more into that, it automatically loops anyone who's questioning the narrative into this other category. And then it just further perpetuates the divide. And it's like, we're not here to divide. What we're here to talk about is the hallmarks of democracy, the hallmarks of scientific evaluation and methods has been bypassed. And that is something that we must bring awareness to. And ivermectin, that was given in countries that are poorer than the first world countries, fared better. Ivermectin won a Nobel Prize in 2015. American frontline doctors, which I've watched a lot, I've been in communication with, they treated a lot of their patients, their COVID patients, with ivermectin, and they were able to get them out of the hospital. That is lived experience with minimal bias, because these doctors are not being incentivized. And it's like you break down the research, guys. Ivermectin is $40. A ventilator to the province is anywhere from $7,000 to $14,000 a day. And that's how we rule a bias. You got to sit down and do pros and cons with bias.
Where are you buying ivermectin for $40? It's a lot cheaper than that, eh?
It's cheap.
It's way cheaper than that. Yeah.
Oh, it's cheaper. Oh no, I'm talking about like shipping and everything. It's like 40. It's like so reasonable. Yeah, I know it's even cheaper than that. And that's the thing. And it's like, but then you take it another step. So why is an anti-parasitic drug working on COVID? Interesting. So that's how you do research. And you know what? It's yes, I'm grateful that I come from my background, and that's wonderful. Am I better than anybody else? Absolutely not. I just have the tools to do research. And so you start by doing your own research. And you know what it is? And unfortunately, we're here because of our society, and we've allowed ourselves through instant gratification that identifies our self-worth. If you read just the abstract of an article and you don't see something you like, you move on. No. Go down to methods, go down to bias. And then you read it. And the first 5 words that you can understand, you highlight, you stop what you're doing because you no longer understand what you're reading, and you go learn. So put down the Netflix, take accountability, and start doing your research. Yes, I have a PhD and I've had so much experience doing research, but it's also up to everyone to be accountable, because this is not just about our lives. It's not about us going back to normal. It's about us evolving from this and learning. And that will not happen if you don't take accountability for yourself. And taking accountability is learning how to do research. Take a course, put down Netflix, put down the bonbons, stop meeting your friends for an hour on Saturdays, put the work forward. And if you're not, then please don't expect me to take the one lens approach. And so much so that I got fired over it. And it's just been like, I'm so grateful though. Like I've learned so much, but it has been a very interesting reality to be living.
Oh, absolutely. The reality check from just how comfortable people are with following orders is a little bit disturbing. And I think part of that is to do with the messaging that we've seen, across both social media, from our world leaders who are supposed to be the people we've elected to look out for us in our best interests, to the healthcare professionals that have blindly gone along with this. Now, you've mentioned the American, frontline COVID care people, American frontline doctors. You've mentioned
American
the
frontline
nursing
nurses.
equivalent.
Canadian frontline nurses.
There are some healthcare professionals that are speaking out and bringing awareness to this, but it feels like it's so few and far between, and there are very many that are happy to go along with doing as they're told and following the protocol and ventilating, or in the US using remdesivir, which is
remdesivir. I can't even remdesivir. So I'll and people not only they're not doing their own research, they're not looking at other sources of research. And this is not an opinion piece. This is not a, up to interpretation. A testimony is a testimony, a testimony that is logged in front of Senate, or that is logged in front of an entire appeal or grand jury, whatever. That's real. That's a real testimony. So American Frontline Nurses founder, the entire team in American Frontline Nurses, by the way, shout out, these women are women and men are heroes. And the founder, Nicole, I will say her last name wrong. And she went on, testified between the weeks of January 17th, I believe, to January 26th. And it's on record. And she testified because she was one of the original nurses that got sent to NYC to help all the COVID crisis there, because it was a hot zone. And she whistle blew against what was truly happening. And that's what led her to found this organization. And so she is also a biochemist by trade as well. And it's recorded, it's testimony where she explains that remdesivir and her lived experience was killing patients 50 to 75% more likely to kill a patient, because it puts them into multi-organ failure. And that's log testimony now. It was in front of Senator Johnson, I want to say. I might be off
Ron
a little
Johnson's
bit.
COVID second opinions.
Exactly. And so it's a recorded testimony. And she's an ICU nurse. She's obviously no longer working. And she's created this beautiful, beautiful institution from all of the darkness. But, she testified, and her testimony was substantiated with 6 or 7 other experts that discussed that early treatment, including ivermectin, should have been a hallmark. And so it's I know it's not being broadcasted on mainstream media, but also if you're going to align yourself and position yourself to be so close-minded, then I want to ask why. Please tell me you've done all your research, right? Because being close-minded is not just affecting, your life. You're talking about people losing their jobs. You're talking about suicide attempts. So if you're going to align yourself with a kind of a dangerous narrative, and be so solidified in your thinking, please tell me that you've looked at alternate sources of knowledge and resources. And one of them is Nicole Sturrock has testified with 7 other experts in the field, saying what lived experience, and then also bring in what their knowledge. And she compared, and the entire audience at this hearing stood up when she compared the hospital systems to working more now like a concentration camp. And I know that's a lot to wrap your head around.
That's really rough. I know. I don't know. I know why people are using the comparisons, as for some it feels like that's the only way we can go. But in that instance, I'm hesitant to get on board with that one. I can see the isolation of people as those first steps pre-camps. I can totally see that, and where people are being called dirty for being unvaccinated or what have you. It's very similar to the propaganda that was used prior to the camps being introduced and all the rest of it. People being shut out.
You've seen the similarities. You're seeing them.
Absolutely. But the concentration camp hospitals, that's a stretch for me. I mean,
I know, but she said that she was comparing that to what was going on in New York, and so the testimony is wild. I mean, it's wild. It's wild.
The stats on remdesivir as well, the study that they used to justify it, actually, they saw the exact same statistics in that they were having 50% fatality rates with remdesivir. It was compared to, I want to say, 3 other drugs in the trial that was used by those in the power that be to justify it. They also saw multi-organ failure, kidney failure, what have you. And it's a known element, and yet still pushed along as, hey, this is the drug we're going to use, which again, what you spoke about with financial incentives, and this is very easy to find for anyone that wants to look this up and fact check this. Perhaps I'll put a link in the description.
Yes.
I think it's $3,000 for every remdesivir script that's written. Yeah, come on. You're telling me there's no incentive for a hospital to say, hey, listen, as part of our protocol, this is what we're going to do. And sometimes doctors' hands are tied in the same way that doctors and nurses aren't able to prescribe ivermectin or HCQ. They're forced then to use remdesivir, even if it's against their better judgment and they know it's not going to help.
Yeah. But and like, you're right. Like, my issue though is that, like, I just don't understand too, like, working and say you're giving the drug. How do you not, looking at your patient's biochemistry and their lab work, how do you not identify a pattern looking at the drug? And I guess it's, is it fear? Is it they're so burnt out? There's so many angles that you can tackle this. And it's not, again, to blame fingers and say like all of healthcare is super evil. No, but in order for us to evolve from this and grow from this, we need to understand why. And I just, like, it's so obvious when you give a patient remdesivir by all the studies coming out, like it's there in your face. It's multi-organ failure. And if you're giving it more than once, good luck. If you're giving it twice. So besides the financial incentives, besides the blood work, besides the common themes that we're seeing, why are we not questioning it? Why are we not, and that's the part where we need to bring awareness to and evolve from and grow, because it needs to happen. And why just remdesivir? Why can't any other, like, why not other drugs, right? Or why not other, why aren't we doing study groups and people volunteer to be part of the vaccine? Wouldn't people want to volunteer to be part of the ivermectin treatment protocol? Like, so if we could apply that one lens to the vaccine, can't we do the same with ivermectin? So, and like we said, these are the things that are being steamrolled that deserve attention moving forward. So that, like Nicole Stork said, so that we don't make it into concert, so that we get away from that paradigm of evolving towards the total end of genocide. And I think her comparative was just that the hospitals are operating in a very dangerous route right now, and they need to come back up for air. And that comes through honesty, that comes through, addressing the cognitive dissonance, addressing the people that had been financially incentivized, and then getting and building that trust back up with the public, because I know the public is not really trusting right now. And I've seen it. That's another thing we've been living. Patients are not coming in and they're having like heart attacks at home, or they're not coming in to, they have lumps in their breasts and they're waiting till the lump opens up and is weeping because they're so terrified. Right. Jeez. Yeah. So it's like, look what's happened from this one thing, and look how much it has a snowball effect. And we're not talking about the snowball effect, and we're not addressing how it became a snowball effect. Because if you do, you were grouped into, or you're a denier, and how dare you, my family member died of COVID. And it's like, it's a very interesting time right now. Very, very interesting time.
Yeah, absolutely. And I think what you mentioned there, of we're not addressing why we've come to this point, I think the media and social media have a big part to play in this. And okay, this is outside of our wheelhouse, as we're not journalists per se, but the fact that the messaging was every day with a COVID ticker on the news cycle, with every day talking about COVID hospitalizations and hospital deaths. And then when the deaths weren't enough, they were talking about hospitalizations. When the hospitals weren't enough, they were talking about positive COVID cases. And seeing this slow transformation of continual pressing with this COVID narrative, what role has that played, do you think, especially with those last few patients that you spoke about, people waiting to come into hospital, people waiting to get things checked out? Where do you think that that's played into it from your side?
I think clear and simple for me, and this is just my opinion, I think the media is complacent in crimes against humanity. Sorry, you're there to represent both sides. You're there to share information, and you're of course they shared COVID numbers. That's what they're expected. But did they share the comorbidities? And like we said, don't tell me that you couldn't do it because you were rapidly able to tell us who's unvaccinated and who's vaccinated in the ICU setting for Canada. So it exists. The ability for us to be transparent with data exists, and it was not done. And you're seeing it now. They're starting to flip as more and more evidence comes out against it, and they're flipping and saying like the CDC or the WHO, oh, well, most of the people, had 4 comorbidities, or, natural immunity is showing to prove, I think, what is it, 7.4% more likely to combat all the variants. Like, so it's like, but that stuff should have been shared. And if we were not previewed to that knowledge at the time, then a disclaimer needs to go out like that. So I think the media is 100% complacent in crimes against humanity. And you need to look at who's funding the media. So, because we made our decisions based on the media, like, right? We made, and we've allowed our friendships, our relationships, our families to be broken and devastated over this, and that we own those actions. But a lot of the actions came from a place of where they thought they were getting the information that they were supposed to be getting, and they weren't, because it wasn't transparent. It was only a picture or a fraction of the story. And to me, it feels like the fraction of the story that propagated a specific narrative and not the whole. And if you don't have the whole picture, how do you evolve? How do you identify your holes? How do you identify your strengths? How do you learn from it when you're only seeing a sliver, when it's in fact super layered? And they didn't do that. Never did that. And they've never apologized. They falsely reported data. And we're just like, oh, today the CDC or the WHO says, okay, but that's not okay. They need to be held accountable, right? And we're allowing it to just oh, it's okay, they messed up, and it's
sweep it under the rug of, yes, oh yeah, they're allowed to. Yes. But if you or I was to misquote some figures in this, we'd be strung out. If I get by bootstraps. Done. And if I get in that, and that's what being a healthcare is. You're in a position of privilege to be looking after someone in a vulnerable state. So I understand having that strong moral compass of, if you do this, or if you give a medication wrong, you're going to be in trouble. That makes sense. But if the media does it, there's no. It's the media. They're allowed. Are you familiar at all with the Trusted News Initiative? No. No? Okay. So what you mentioned about the information coming out from the media and the only giving part of the information, only giving part of the story, yada, yada. So the Trusted News Initiative was created by the BBC in partnership with organizations like Facebook, Twitter, Reuters, Washington Post, etc., etc. Big news companies. And they were created to disrupt and prevent vaccine mis or disinformation. And also, importantly enough, if you look into the Trusted News Initiative in some of their first press releases, vaccine hesitancy. And that, I think, is a major key, because vaccine hesitancy can be a lot of different things. Can be early treatment, which is something that we saw was wiped off the face of the planet. Can be talking about potential adverse events. There's again, I think in Senator either Ron Johnson's COVID review, or another senator, where there was the young child that was misrepresented in the Pfizer trial data for the serious neurological event, and written down as stomach cramps or something, stomach pains. Stories like that are from trial data, that are factually based, that are at risk of perjury or what have you. They were eliminated and censored. Censored. If you spoke about them, you'd be pulled down, you'd be taken out. Threatened. Yeah. And I think that's also something where people need to realize there is this massive bias with the mainstream news networks, classical news, of, look, we have an agenda to push. And it's not me saying it. You can look up the Trusted News Initiative and find what they have said and how they are going to do it and how they are going to prevent any hesitancy or what have you. So precisely, this is also something where it swings into the role of the media in us coming to the position we're in now, I think. And in Canada, there's been this really big push over the weekend to stop with the mandates. And that has also been negatively portrayed in the Canadian media. Shall we put it like that? Yes. Yeah.
Absolutely. Absolutely. And it all ties in. And so Canada is a massive revolt revolution, and it's beautiful to see. And it is being, we use the word demonized, like, because that's exactly what it's happening. It's the real, truth of what's going on, or an open dialogue, open forum is not being created by the media. What's happening is that it's demonizing, diminishing, trying to demoralize the importance of the movement. It's again, when you align yourself and you're trying to bring awareness, because we're in such a state of cognitive dissonance right now, and we're still so angry, we're so divided, that the second you say something, you can't even have a critical discussion. You are automatically looped as, the crazy or whatever, white supremacy. So that's what's going on right now, is that the movement is being coined as a white supremacist, racist movement. And so here's my stance: do we systematically, as an entire culture and society, have to be better in racism? Without a doubt, we have to be better. Does this movement, in my opinion, is white supremacy? I don't think so at all. And there's been Indigenous members coming forward and supporting. And then there's even the Freedom Convoy, which is upwards of 300,000 people now have joined on Instagram. They with another account called the POCs, so People of Color Freedom Convoy, and it's trying to bring back truth, which is what the media should be doing both sides for people to decide, trying to bring back truth. And so showing a bunch of people of color saying, I support that, I came to this country 10 years ago from Ghana, from Nicaragua, from Africa, from Iran, whatever, and they're just supporting and saying, like, please don't loop us all together. We stand with you guys. Because right now in the media, it is just saying white supremacy. And again, I'm not saying that there's a couple bad apples in the movement. Yeah, there might be, but to paint an entire amazing movement as such is like, we're not learning from COVID. We're applying the same mistakes that we haven't learned from into this domain. And it's like, let me put it down for Canadians who are still on the fence. And please, I encourage, message like, so we can have these open conversations. But if 36,000 truckers in Canada get fired, famine doesn't care what race, religion, what culture you are. It doesn't care. Famine is famine. You know what I mean? You can't, inflation, which is essentially a subgroup of famine. It doesn't care. It doesn't, if you're not from the right sociodemographic background, you will perish. And that is something that we cannot allow. We've bypassed informed consent with the vaccination because people aren't getting the real picture because of the media at large and the politicians. But this is another example. If we don't win this for Canada, 36,000 truckers will be off the roads. I'm sorry. Like, I am not going to stay quiet and feed into the whole white supremacy agenda when famine does not care what color, like what race, what background you are from. So and this is another level of cognitive dissonance. Like, again, I'm not saying that there aren't bad apples. I'm not saying that there isn't room for improvement. I'm not denying everything, but I am also very aware that what will happen if this doesn't fall, if this doesn't, if we don't come up on top with this. And the worst part of all of it is that this movement is rooted in love and support. And look at what's happening with the People of Color Instagram page, how it's taking off and uniting people. And also, we've raised over $6 million for the truckers in Canada, but they've also raised over $500,000 in 3 days alone for the drinking water that Justin Trudeau promised the Indigenous communities. So how can that just be white supremacy when the evidence is right in front of you? And if you try and bring awareness, or you try and foster these open dialogue, you were looped into being crazy, to being racist. And it's like, it's very interesting, because it's like, haven't we learned that this is not the way moving forward? This judgment, this lack of respect, this lack of open-mindedness, this lack of critical thinking, lack of debate has gotten us to de-evolve versus evolving, right?
Yeah.
So, and the media is part of it. The media is a big part of the division. And who funds the media? These are the questions that we need to start asking. It's not us versus us. It's corporations that are not being transparent and honest, that are being valued in our society as institutions of sacred origin. Like, the media is supposed to be an information resource. The hospitals are supposed to foster democracy and scientific methods. And we're getting so far off of that. And we're not talking about bringing this back to center. And that is a problem. And it's happening again with the Freedom Convoy. And like, I just can stress it again, if we don't come out on top, and I'm not a doomer, I have so much hope for humanity. Famine does not care. So white supremacy or at all, it does not care. Famine doesn't give a shit. So
absolutely not. And it's strange to see that it's being portrayed in the Canadian media as a white supremacy movement. I've not read that. Looking at the Dutch media or looking at the British media, it's really, really baffling to see that in the age of information and technology, that these media companies believe that people won't look around. And that's actually something that was put out by, I think it was the BBC, saying don't do your own research. So perhaps they hope that people won't look deeper into it. But the whole reason that they're protesting, absolutely. But the whole reason that they're protesting is because of the vaccine mandate, where, like you say, 36,000 of them are going to lose their jobs. Now, something we're not going to dive too deep onto is the fact that in Austria, the head of bioethics is now saying, hey, actually, now that we mandated the COVID vaccine, we should look at mandating other vaccines as well. Their situation's really dire. But it's again, this snowballing effect of, hey, if we can do it once, we can do it again. If we can lock down once, we can lock down 5 times. Now, what do you think will be the prolonged effect of these vaccine mandates on healthcare? As it's something they're currently fighting in the UK. And I've got some friends that are on the front lines trying to stop these mandates from coming in, as the NHS would all but collapse if these vaccine mandates come in.
Right?
Well, the NHS itself is funded by the people, but it's also, the government supply the funding. However, that's been cut over the years. But it's funded by tax money. But in Canada, unfortunately, it's already happened. And I don't know what the movement was like prior to the healthcare mandate coming in. I do have some friends that work in healthcare in Canada that they, against their own will, got the jab because of the whole necessity behind it. What's the long-term effect going to be of this mandate on healthcare there?
Well, and that's too, I also want to bring a lot of attention to people that are still working in healthcare. Not everyone's evil, right? We don't want to get back into this stigmatizing and generalizing. I know a lot of friends that had to comply because they're single parents, or they have a house, they have kids, and they're scared, and they're us, they're humans, we're human. And a lot of them, some of my friends have a couple autoimmune diseases, and so they need the drugs, they need the drug plan to sustain, right? So 100%. But so the effects of all this relates to all of this. The effects is, now you have so my organization springs across 7 hospitals, and just my hospital alone, 200 were terminated healthcare workers. That could be a mix of nurses, doctors, porters, X-ray techs, whatever you have that sustain the hospital. 200 got fired. Approximately when I left, there was 300 registered nurse positions or registered practical nurse positions open. So now we fired 200. When I left, there was 300 open positions for nurses. I approximately 200 were off on a sick claim already. And then with retirements and everything else, people had just left. So how devastating is that to healthcare function? And then a lot of people got coerced into doing it. So do you think that they're going to be the happiest they can be going into work, knowing that they had to do something that and I'm not saying these people are causing poor outcomes, but in terms of your satisfaction, and we know that when you're satisfied and really feeling like you're living your purpose, it's going to show in your work. Well, how do we, and so tack in now being extremely dangerously short-staffed, with all of the mandates, people losing their jobs, walking out, retirements, people going on sick claims. And now you just have the nurses that are there, they're burnt out, they have PTSD, they're angry. And it's like, how does this create good outcomes? The team dynamics are crap. So that affects, all of these things affect healthcare. And it's like, where's the conversation of that, right? And right now what Canada's fighting to is trying to equal pay. And it's not a misguided, I'm happy people are standing up and are trying to, get their voices. That's great. But we have far more devastating issues to tackle in healthcare than fair pay. It's a big part of it, but a lot of it is the vaccine mandates. Look what they've done.
Yeah.
Those are bigger. You know what I mean? Those are bigger. So it's, I feel like we are working in the right direction, to be honest. I don't want to be doomy and gloomy, but I cannot downplay the fact that we have so much work to do. so much work to do to bring awareness to these issues, to get back to our moral compass, to not allow bias to overrule, your sense of humanity, and to rule out bias, to create a framework so we can have these open forums, to debate, to, who funds this and how does that play into financial incentives, and the cost risk benefit analysis of decisions from politicians that do not work in hospital settings, right? How does that affect it? And look, like the hospitals are down 1,000 staff. There was one hospital in Orangeville that, and this was released, again, this is hard evidence, where they asked their kitchen staff to step in on the floors. How does that create safe outcomes for the patient?
I'm sorry, where?
Yeah.
What?
There was a hospital in Orangeville that they asked the kitchen staff to step in to help.
How are they even allowed to?
Precisely. So
how are they even allowed to do that? How are they even allowed to touch patients?
I don't know. And that's what I mean. Like, that's scary. That should never have been allowed. Like, that should, the community should be up in arms about that. But we're so divided with social media that we're not tackling the big pressing issue. So yeah.
Your microphone.
Sorry, can you hear me now?
Yeah, that's better. Sorry, you're saying
Okay.
We're so divided because of the media.
We're so divided because of the media that we're not tackling the core issues, right? So
what would be for you the biggest things that you would like people to take away from this conversation? What would be your highlights?
Do your research. If you don't know how to do research, then that's where you start. You identify that I don't know how to do research, and that I'm going to, whether it's take a course or I'm going to sit down and learn, or I'm going to start reading an article. And the second I highlight 5 words, I put this research down and I figure out those 5 words that I don't know about so that I can further break down this research. So that's one, taking accountability, creating frameworks for you to be empowered with research. And part of it is saying, I don't know how to do research. I don't know statistical analysis for validity, credibility. And this is coming from a place of love. Like, I have had so much training to be able to do this. I know it's not easy. I understand that, but it's also your job to put down the TV, put down the distractions, and equip yourself to be empowered. So that's one, have an open mind, and start fostering tough decisions and start fostering tough conversations with, people that might have an opposing view, because that's how you learn. I don't claim to know everything. Absolutely. But I can assure you that I'm willing to sit in a room and hear a bunch of different opinions to make my opinion, right? I'm very open-minded. And if you're not, then that's somewhere that there's a point for you to start. I am not an open-minded person. Okay. So self-awareness, right? And start going out and seeing what you're feeling, think, feel, and act on that. So go out to one of these rallies and see, are there people lighting things on fire? Are people spreading hate, or is it surrounded by love? And go from there. So take your lived experience, take your learning gaps, empower yourself, face your demons, have tough conversations with people that have opposing views, and hear them out, because there might be an area for you to learn. And that is called evolution, and that is called consciousness. And that's how we propel ourselves forward. But if we're not doing any of those things, what is the definition? What is the definition of insanity? If you continue to do the same thing over and over again and expecting a different result, guys, we are living it. We are doing the same thing over and over again and expecting a different result. Lockdowns, vaccination mandates, which have far more crippling effects on economies and morals and values on families and friends than COVID. Like, it's just, we need to get back to a framework of empowering ourselves, and it comes from within. That's pretty much my takeaway.
Fair enough. And I think I want to highlight on that research aspect. There's 2 things. One, also learn how to appraise the research that you're reading.
Yes.
And 2, don't just go from Auntie Sue on Facebook, because there's so much crazy stuff going out there as well.
There's so much. Yeah.
I saw one video that was claiming to be a microscopic view of the vaccine, and it had basically the alien from what was the movie? Basically an alien from some sci-fi movie moving about in the fluid, and people were taking this to be factual. And you have to be able to discern what people are using to mess with you, and ascertain what's good information and usually going to a journal is a good idea, using something like PubMed to look into it. However, there's also the regulatory capture, the capture of the scientific studies as well, who funds those studies. But another one to highlight is the difference between absolute risk and relative risk. And this is something that is massively being manipulated at this point in time, especially with the data from current trials, current studies. You know, when we look at the vaccine adverse events, people are then trying to compare those to what can happen in an adverse event from the virus itself. And yet, when you break down the data, there seems to be a lot more that can potentially go wrong from the vaccine side, also depending on your age and whatnot.
Exactly. And when people from different, and I don't downplay how confusing this is. Like I feel so much for the world right now. Like it's confusing. We're all going through our own spiritual awakening or our own type of awakening to what's going on. We are living it. We are seeing the families divided. Our friends have stopped talking. Like I understand how devastating this is and how it's like, you want me to put more work when I'm depleted, I am exhausted, but it's about re-empowering yourself with the tools to never make these mistakes again, or not to never make these mistakes again, but to learn from these mistakes. And for me, I share a lot of information. So I shared the FDA patent from the Pfizer vaccination. Again, this is hard evidence. I did not create this. This is a license approved patent document from Pfizer, 53 pages. I leaked that. No one even, people barely batted an eye. I leaked the FIOA request, which is a Freedom of Information Act, which grants the public access to federal documents. And it was created for things like this. So through the FIO request, I've leaked the 38-page conversation of Pfizer reporting to the FDA all of their adverse effects. Again, that is not an opinion piece. That is a hard fact. These documents are from Pfizer to the FDA. I leaked the Sick Kids 19-page PDF, and Sick Kids, if for those who don't know, it's a top institution for children's hospital in Canada, one of the top 3 in all of Canada. And they created a 19-page PDF on how to treat your child post-vaccination injury. So again, this is hard evidence. And the thing, where was that shared on mainstream media? Because that's how informed consent works, right? You can get the vaccine, but here's the cons. Here's what might happen. Okay, great. If you decide to get your child vaccinated, all the best to you. That is on you. And you were provided informed consent, and I can carry on with my day. But those things are hard facts, and they're not being spoken about, right? Nurses, testifying, in front of different organizations. Why aren't we talking about that? And that's what we need to get back to. And that's why we need to develop frameworks so that this kind of stuff never happens again.
Yeah, no, absolutely agree. Tiffany, I really want to thank you for your time and talking to us. What do you think is the thing that we're not looking at this point in time that you think our attention should be going towards?
Because I come from, an energy background and a healing background, I think that, I'm happy we talked about this, and I hope people can take away from this. And if they want to message me too and break down some stuff that I talked about, please, that's how we learn from each other. But I hope more than anything that we need to work on our forgiveness. And it's hard, but if we want humanity to propel forward and to evolve, we're going to have to start forgiving each other for this, and on all spectrums. And I think that's another big thing.
That's beautiful. That's a nice way to finish up, I think. Yeah. Thank you very much. Appreciate it.
Thank you for having me.